Today, we are going to cover the effects of exposure of the human body to extreme environments. What characteristics must an environment have for it to be considered extreme? The answer is related to human survival. And so we ask, what are the four basic needs for human survival? Is it fire, water, air, and soil? Is it shelter, fire, water, and air? Is it food, water, fire, and shelter? Or is it water, shelter, air, and food? The answer is letter D. An extreme environment is a place where human survival is difficult or impossible. In order for human survival in an environment, the four basic needs must be available. For example, in a polar region, it is difficult for human survival because it lacks shelter and has extremely cold temperatures. Similarly, space doesn't have any of the four needs of human survival occurring naturally in it, and therefore, technologies such as spacesuits and the International Space Station are requirements for human survival in space. And so how then are we going to describe extreme environments? Are they places that are exhibiting extreme conditions that are challenging to most life forms? Or are they places that humans may explore? Or are they those kinds of places that require special equipment and technology to explore? Or are they places that include space, high mountains, polar ice caps, high salinity waters, and deserts? Or all of the above? While extreme environments are places that people can explore, there are places in which it is very difficult and or impossible for human survival. As an example, the extreme environment of space does not allow humans to breathe, at least on their own, nor does it have its own supply of water. Humans may not survive in space without the appropriate technology that would enable them to do so, such as the International Space Station. And so we came into the question of what are the consequences of exposing the human body to these extreme environments. How will our body respond to high altitudes, aviation, and space, as well as hyperbaric conditions as exemplified by deep sea diving? Let us first look at how our bodies are affected by exposure to high altitudes. So this is a photo of our group from Cagayan de Oro City who went out on an adventure to Everest Base Camp last April of 2019. There were 6 of us, all doctors, a pediatric surgeon, a pediatric intensivist, a pediatric nephrologist, a pediatric hematologist, an orthopedic surgeon, and an obstetrician gynecologist. We were accompanied by our tour guide and 2 Nepalese guides. It was a 60-plus kilometer trek with an elevation gain of 2,000 plus meters spread out in 12 days on a terrain of rock and ice. Other than the spectacular scene unfolding before our very eyes is that nagging possibility that we might not be able to come out alive from that hostile environment. The closer we got to our destination, the harder it became to walk and breathe at the same time. So why is it very difficult to breathe in these elevations? The decrease in barometric pressure is the basic cause of all the hypoxic problems in high altitude physiology because as the barometric pressure decreases, the atmospheric oxygen partial pressure decreases proportionately, remaining at all times slightly less than 21% of the total barometric pressure. At sea level, the partial pressure of oxygen is about 159 millimeters mercury, but at 50,000 feet, the partial pressure of oxygen is only 18 millimeters mercury. Take note that the numbers in parentheses are those related to acclimatization values, and we will discuss acclimatization later on. Let's look at the fifth column of this table. It shows the approximate partial pressure of oxygen values in the alveoli at different altitudes when one is breathing air for both the unacclimatized and the acclimatized person. At sea level, the alveolar partial pressure of oxygen is 104 millimeters mercury. But at 20,000 feet, it falls to about 40 millimeters mercury in the unacclimatized person, but only to 53 millimeters mercury in the acclimatized person. The reason for the difference between these two is that alveolar ventilation increases much more in the acclimatized person than in the unacclimatized person, as we are going to see later. Some of the important acute effects of hypoxia in the unacclimatized person breathing air beginning at an altitude of about 12,000 feet are drowsiness, lassitude, mental and muscle fatigue, sometimes headache, occasionally nausea, and sometimes euphoria. These effects progress to a stage of twitchings or seizure above 18,000 feet. Ascent to 23,000 feet in the unacclimatized person can result in coma, followed shortly thereafter by death. So can lowlanders overcome the challenge of high altitude? The answer is yes, if they can acclimatize to the altitude. So what is acclimatization? Acclimatization is the process by which an individual adjusts to an extreme environment. A person remaining at high altitudes for days, weeks, or years becomes more and more acclimatized to the low partial pressure of oxygen, so it causes fewer deleterious effects on the body. After acclimatization, it becomes possible for the person to work harder without hypoxic effects or to ascend to still higher altitudes. The principal means by which acclimatization occurs are as follows. There is a great increase in pulmonary ventilation. There is increase in the number of red blood cells. There is an increased diffusing capacity of the lungs, increased vascularity of the peripheral tissues, and increased ability of the tissue cells to use oxygen despite low partial pressure of oxygen. The respiratory system acclimatizes to high altitude via responses to hypoxia that aims to improve tissue oxygenation through increased pulmonary ventilation and diffusing capacity. Immediate exposure to low partial pressure of oxygen stimulates the arterial chemoreceptors, and this stimulation increases alveolar ventilation to a maximum of about 1.65 times the normal. Therefore, a compensation occurs within seconds for the high altitude, and it alone allows the person to rise several thousand feet higher than would be possible without the increased ventilation. If the person remains at a very high altitude for several days, the chemoreceptors increase ventilation still more, up to about 5 times the normal. The immediate increase in pulmonary ventilation upon rising to a high altitude blows off a large quantities of carbon dioxide, reducing the partial pressure of carbon dioxide and increasing the pH of the body fluids. These changes inhibit the brainstem respiratory center and thereby oppose the effect of low partial pressure of oxygen to stimulate respiration by way of the peripheral arterial chemoreceptors in the carotid and aortic bodies. However, this inhibition fades away during the ensuing 2 to 5 days, allowing the respiratory center to respond with full force to the peripheral chemoreceptor stimulus from hypoxia, and ventilation increases to about 5 times the normal. The cause of this fading inhibition is believed to be mainly a reduction of bicarbonate ion concentration in the cerebrospinal fluid as well in the brain tissues. This reduction in turn decreases the pH in the fluid surrounding the chemosensitive neurons of the respiratory center, thus increasing the respiratory stimulatory activity of the center. An important mechanism for the gradual decrease in bicarbonate concentration is compensation by the kidneys for the respiratory alkalosis. The kidneys respond to decreased partial pressure of carbon dioxide by reducing hydrogen ion secretion and increasing bicarbonate excretion. This metabolic compensation for the respiratory alkalosis gradually reduces plasma and cerebrospinal fluid bicarbonate concentration, and the pH goes towards normal and removes part of the inhibitory effect on respiration of low hydrogen ion concentration. Thus, the respiratory centers are much more responsive to the peripheral chemoreceptor stimulus caused by the hypoxia after the kidneys compensate for the alkalosis. The normal diffusing capacity for oxygen through the pulmonary membrane is about 21 ml per millimeter mercury per minute, and this diffusing capacity can increase as much as threefold during exercise. A similar increase in diffusing capacity occurs at high altitudes. Part of the increase results from increased pulmonary capillary blood volume, which expands the capillaries and increases the surface area through which oxygen can diffuse into the blood. Another part of this increase results from an increase in lung air volume, which expands the surface area of the alveolar capillary interface still more. A final part results from an increase in pulmonary arterial blood pressure, which forces blood into greater numbers of alveolar capillaries than normal, especially in the upper parts of the lungs, which are poorly perfused under usual conditions. Other components of respiratory acclimatization are the increased pulmonary arterial pressure and hypoxic pulmonary vasoconstriction that aids in increasing the flow of deoxygenated blood to the lungs to improve oxygenation of large volume of blood in short duration. Hypoxic pulmonary vasoconstriction occurs, which is a very interesting phenomenon where, compared to the vasodilation observed in the general body, the pulmonary vasculature constricts in response to hypoxia. To improve blood oxygenation during hypoxia, hypoxic pulmonary vasoconstriction occurs to direct the blood supply to selective alveoli with higher oxygen content to further enrich the ventilation-perfusion ratio. What about the cardiovascular system? How does it respond to exposure to high altitude? As the altitude increases, in order to restore oxygen delivery to the tissues, increased cardiac output is observed along with increased velocity of blood flow, a rise in pulse rate, observed within the first 12 to 36 hours. The raised cardiac output is maintained only in the initial period of stay at high altitude and is then normalized within a few weeks of stay at altitude. However, due to continued pulmonary vasoconstriction, the right ventricle has to exert more force, leading to a marked increase in pulmonary artery pressure and right ventricular hypertrophy. The left ventricle also goes into hypertrophy due to the same reason of excessive pumping action. Let us now take a look at the hematologic responses to hypoxia. Since arterial blood is the principal oxygen carrier in the body, raising the arterial oxygen content is the most important physiological adjustment to mitigate tissue hypoxia. Improvement in arterial oxygen content occurs by increase in hematocrit hemoglobin, and erythrocyte levels during hypoxia exposure. This boost in oxygen-carrying capacity is a direct outcome of erythropoietin secretion from the kidneys into the bloodstream within 2 to 3 hours of hypoxic exposure. Erythropoietin triggers erythropoiesis, or red blood synthesis in the bone marrow over the period of stay at high altitude. Acute acclimatization is also associated with diuresis as described previously. This facilitates loss of body water, leading to reduced plasma volume, thereby effectively increasing the proportion of red blood cells per unit volume of blood, a phenomenon called hemoconcentration. Hemoconcentration is an efficient way to increase oxygen-carrying capacity of a given volume of blood. Another circulatory adaptation is growth of increased numbers of systemic circulatory capillaries in the non-pulmonary tissues called angiogenesis. This adaptation occurs especially in animals born and bred at high altitudes, but less so in animals that become exposed to high altitudes later in life. In active tissues exposed to chronic hypoxia, the increase in capillary is especially marked. For example, capillary density in right ventricular muscle increases markedly because of the combined effects of hypoxia and excess workload on the right ventricle caused by pulmonary hypertension at high altitude. In animals native to high altitudes, cell mitochondria and cellular oxidative enzyme systems are slightly plentiful than sea-level inhabitants. Therefore, it is presumed that the tissue cells of high-altitude acclimatized individuals can use oxygen more efficiently than their sea-level counterparts. In addition to respiratory, cardiovascular, and hematologic changes, there are also metabolic adjustments to hypoxia encountered in high altitude. 2,3-diphosphoglycerate is a special intermediate of glycolysis in erythrocytes, which is rapidly consumed under conditions of normal oxygen tension. However, when hypoxia is encountered in peripheral tissues, the concentration of 2,3-DPG can accumulate to significant levels within hours. At these concentrations, 2,3-DPG can bind to the hemoglobin and reduce its affinity for oxygen, resulting in a rightward shift of the oxygen-hemoglobin dissociation curve, as discussed before in oxygen transport. This results in enhanced unloading of oxygen by hemoglobin and thus results in enhanced oxygen transport to tissues encountering long-term hypoxia. A small percentage of people who ascend rapidly to high altitudes become acutely sick and can die if not given oxygen or rapidly moved to a low altitude. The sickness begins from a few hours up to about 2 days after ascent, and two events frequently occur: acute cerebral edema and/or acute pulmonary edema. Acute cerebral edema or high-altitude cerebral edema is brought about by hypoxia that leads to local vasodilation of the cerebral blood vessels. The increased blood flow into the capillaries increases the hydrostatic capillary pressure, and this leads to fluid leak into the cerebral tissues. The resulting edema causes severe disorientation and other effects related to cerebral dysfunction. Acute pulmonary edema or high-altitude pulmonary edema, on the other hand, is due to severe hypoxia, which leads to pulmonary arterioles constricting potently. This constriction is much greater in some parts of the lungs than in other parts, and hence more and more of the pulmonary blood flow is forced through fewer and fewer still unconstricted pulmonary vessels. The high capillary pressure develops in these areas of the lungs causes local edema, and extension of the process to progressively more areas of the lungs causes the spread of pulmonary edema, resulting in severe pulmonary distress. Here are some tips to increase your survival as you ascend into high altitudes. If you go above 10,000 feet or around 3,000 meters, only increase your altitude by 1,000 feet or 300 meters per day, and for every 3,000 feet or 900 meters of elevation gained, take a rest day. Climb high and sleep low is the maxim used by climbers. You can climb more than 1,000 feet or 300 meters in a day as long as you come back down and sleep at a lower altitude. This will allow your body to acclimatize to higher altitudes. Rest sufficiently for the initial 72 hours. Take plenty of fluids to avoid dehydration and high fiber and low salt nutritious foods. Use snow goggles, wear layered clothing to keep yourself warm. Avoid physical exertion. Do not walk too fast or exercise. Climbing a mountain is not a race, and therefore the most important thing to remember is to pace yourself and make sure that you come out alive. Refrain from alcohol consumption and using sleeping pills because they can interfere with your respiratory system. Do not continue climbing higher altitude if signs of mountain sickness appear. And most importantly, do not hesitate to take medical help or descend if physical and cognitive health deteriorates.